So I'm going to be demonstrating two ways to approach working with the sacrotuberous ligament, and as a prelude to that I'll be working with the gluteal fascia where it attaches at the sacrum, and also there's a blending of the fascia that comes from the thoracolumbar region into that same site, and we have therefore a quite useful area to start working. There's a lot of fascial attachment there, and doing that as a preliminary release before working with the deeper, more significant sacrotuberous ligament. The contact will be starting at about, and it doesn't have to be precise, the spine or the intermediate spine of the sacrum, and here I'm showing this work done with my fingertips, finger pads, working with both hands and just bringing the direction of my movement is towards the trochanter. I can feel myself getting here to the edge of the sacrum and starting then to drop away more into the gluteus maximus. And this can feel very pleasant to get this work done around the ligamentous structures that hold the sacrum into the innominate, and also very useful for clearing the fibrous restrictions that build up in here so frequently. And so many times there'll be a number of trigger points in here, as well as quite obvious fibrous change. And this can be done at a number of sites along the edge of the sacrum. It can be from the PSIS all the way through effectively to the lateral portion of the coccyx. And once again, we're using our fingers and our palpation to ascertain where the areas of restriction are and focusing on those. The sacrotuberous ligament, as the name tells us, runs from the sacrum to the ischial tuberosity, so we've effectively got a ligament that's running in this territory here. Now we've got this deep ligament that runs through the fascia of the gluteus maximus. So it's embedded in the fascial fibers of the gluteus maximus and is continuous with the fibers of the biceps femoris. It's a very important part of the kinetic chain of movement up through the back of the body. And so the transmission of movement through from the leg into the pelvis and into the trunk, the sacrotuberous ligament plays a part in that, as well as being an important stabilizer of sacral position. I'll show two ways to do this. One is with the patient lying in the prone position, and that's what I'll show first, and then with the patient inside lying. Here in this method I'm working through the overlying gluteus, and using the broad contact of my elbow to contact the deeper structure, which is the sacrotuberous ligament, of course. That's done as a slow melting style of work. I don't want to work too rapidly through that. We don't want the gluteus to go into some kind of, provoke some kind of muscle guarding, and you'll see that if you work too quickly there, that the glute will cinch up to try to protect, and so we want to work in such a manner that we don't get that, provoke that kind of guarding, and keep feeling for that deeper, more taut band of the sacrotuberous ligament and all the fascial adhesion that can build up along the edge of that where it blends into the fascia of the gluteus maximus. So that's one way to work with that. The other one is I'll have my model lie on her side. In the side lying position, gives us access to a different aspect of the sacrotuberous ligament, so we're able to work a little bit more from inside the gluteal crease, and I can do this quite easily through the undergarment, which is how I'll demonstrate it here. This also starts to create an effect within the pelvic floor, and this is also very useful, and I'll be showing some more specific release for the pelvic floor via the obturator internus, obturator externus in a moment. But let's look at the sacrotuberous ligament. I'll locate the coccyx, and once again I'll locate the tuberosity. So just so I can orient myself, I can know where I'm putting my fingers, and these are the two structures that I want to know about. And then I'm going to bring my finger in centimetre or two below the coccyx, and then use my fingers to sink directly towards the table, and so that's a lateral pressure. And I'll sustain that. That's pressure without movement, because I'm working through the undergarment. The gliding action becomes a little more difficult, so that's pressure done through the undergarment and sustained. And I'll sustain that kind of compressive technique for a minute to a minute and a half until I feel that there's a palpable softening in the underlying tissue. I would also be looking at ways of palpating, again with some sense of specificity, so that I'm not only just working mechanically in that region, but also working to respond to that which I feel and sense under my fingers. And in this instance, I'm just going to shift my fingers slightly more posteriorly and respond to what felt like a more obvious fibrous tautness in that area than the first placement of my fingers. So it's not a great deal of difference, but it's just working out a little bit more of the crease, a little bit posterior this time within the crease, and finding that that's where there's a more distinct band of fibrous change. And that's the way I'm encouraging you to work, that you make a response to that which you feel and start to clear those restrictions in that manner, rather than simply making the contacts be mechanical. We can use the skeleton to look more clearly at the location of the sacrotuberous ligament. It's running from the ischial tuberosity across to the sacrum, so it continuous with the fibers of the long dorsal sacroiliac ligament. Can be located by palpating for the coccyx. So this is going slightly to inside the gluteal crease, finding the coccyx, and then going a little inferior of that and then pushing laterally, and that'll take you onto the medial aspect of the sacrotuberous ligament. We can work with that portion of it approaching the ischial tuberosity. In the prone position, we're more able to contact the entire length of that ligament. It's worth remembering that the sacrotuberous ligament is embedded in the gluteal fascia as well as being continuous with the fibers of the tendon of the biceps femoris. So we have this very important line, continuity up the back of the body through the biceps and into the thoracolumbar fascia. Next we'll look at two ways to work with the piriformis and the hip rotators, the lateral hip rotators. I'll start with the piriformis and then move to a way of working in the posterior part of the trochanter as a way to affect really all of the hip rotators. So we'll locate the piriformis to begin with, and we want to find about the midpoint along the lateral edge of the sacrum, and then locate also the posterior portion of the trochanter, and that's what I'm showing here with my fingers, the landmarks, and this is important that you are able to locate these, and that will help you work with precision into the piriformis. And then at a point about halfway along that line, that imaginary line that I've drawn there, I'll be working with my elbow and using my elbow to sink initially towards the table. So that's anterior pressure. And I'm definitely wanting to work behind the gluteals. I want that effect to be into the piriformis. It's important here that we don't apply overpressure. Overpressure leads to muscle guarding, and so we don't want that to be an impediment to our connection with the deeper underlying structures. So here my client is working very nicely to accommodate the pressure, and she's allowed that to settle in quite deeply. And so when I get to that level where I'm clearly no longer working with the more superficial myofascia, I'm going to put a little bit of a diagonal drag, and so it's lateral and distal, or towards the trochanter is the shorthand way of saying that. The second way of working, I'm going to use the leg as a long lever, and it's always worth checking with your client that this doesn't create any painful torquing at their knee. As long as their knee doesn't feel challenged by this can be a very useful way to work. We can increase some of the mobility in behind the trochanter. And of course, when we're in behind the trochanter, we're affecting all of the hip rotators. So this hand is driving the steering wheel, if you like, and the other hand is, I'm using a soft fist, locating the posterior portion of the trochanter, making good firm contact there, so got a very clear sense of being able to get into the level of the bone. And as I start to feel a response developing, which is what's happening now, so I can feel that there's a progressive sense of softening, ease in the tissue, and then I'll be moving the leg a little bit more out towards myself, and at the same time using that fist to put a little bit more drag from medial to lateral. Here we want to be sure we don't again work with overpressure. We're not particularly trying to take this leg and put it into a position of maximum stretch. We're just trying to encourage all of these tissues to lengthen out without forcing them to the end point and putting them under a stretch, but more a sustained softening and melting, and then using the lever of the leg to augment that. So all of these techniques are very good for working in around the back of the hip. So even for quite deep-seated hip-related pain, dysfunction, all of these techniques are a very useful way to approach the back portion of the hip capsule. Although this one's a little bit too lateral to be right on the joint itself, nevertheless it's affecting a lot of structures that attach to the capsule. Just repositioned. I've brought my contact with my fista inferior of the trochanter, so I can feel a little bit more the shaft of the femur, and that'll put me onto the back of the quadratus femoris. Okay. Earlier I mentioned that I would show some ways of working with the obturator internus, and that's what we're looking at next. I've got my fingers on the ramus of the ischium here on my model, and I can just show you, I can palpate easily here along towards the pubic ramus, and there I'm palpating back along the ischial ramus, so that's coming back around towards the coccyx. And once again, you want to be familiar with these landmarks so that when you go to do these releases you can confidently put your hand on the structures that you're intending to palpate. And so here's some ways to orient. So to affect the obturator internus, we're going to take our fingers to slightly inside the lip of the bone there, or basically into that medial surface of the bone, and that's obturator internus. And obturator internus makes an attachment has an attachment via the fascia of the pelvic floor with the muscles that are of the pelvic floor. So we've got this continuity of myofascia from obturator internus through into the pelvic floor, and this is an excellent way to start to affect those deeper structures of the intrapelvic muscles. I'll show here with my other hand. I take the fingers superiorly so that the pads of my fingers then are resting on that medial aspect of the bone, and then I make a slight compressive force back towards the table. So our understanding of the role of pelvic floor in stabilizing the sacroiliac joint and contributing to the overall stability of the lumbar pelvic region is talked a lot now in the literature about rehabilitation, particularly for low back pain. And one of the things that's often very necessary is to help people understand and sense their pelvic floor, and this works extremely useful for that because it gives them a direct sensory access to that region of their anatomy that can otherwise be very difficult to sense. And it also plays a very important role in helping normalize the tone within that intrapelvic region. A way to deepen the effect of the work is to take, again, the finger pressure back into the same area. So I have a clear sense there of resting against that medial aspect of the ramus of the ischium. And then I can ask my model just for a slight movement of her coccyx in this case, just to introduce a slight pulling back of the coccyx, just a little bit of an anterior tilt as we know, so she's going to slightly anteriorly tilt her pelvis and then slightly posteriorly tilt the pelvis or take the coccyx forward. And so that's fairly simple but also quite useful way of starting to get some movement in the small muscles around the pelvis. So working with what's sometimes called micro movement, although that's a fairly big micro movement, nevertheless, because the movements are small, they're more likely to be using the smaller local muscles around the pelvis. The other thing that is quite useful here is just to ask for the awareness of the breath coming towards the fingers, that the breath can come to meet the fingers, but also that the exhale can leave from here as well. So it can work somewhat also with obturator externus in this position, and that looks all very similar to what I was just working with. It's just that this time I'm going to be sinking past the ischial ramus towards the table and then taking my fingers up on the lateral aspect of the bone. So that's what I've done here, and I'll be showing you that on the skeleton in a couple of minutes. It's almost the same release, it's just that we're now on the other side of the bone and we're taking the contact initially towards the table, and so that's soft tissue, portions of the adductor fascia, and then I'm taking my fingers just up underneath that and directing then the pressure superiorly so that I'm reaching in more to that lateral aspect of the bone, and that can be repeated at a number of sites around the edge of the bone, so I can make that contact in a number of places. So I'm just showing you a couple of the possibilities there for hand placement. So remember, with that one, we're no longer inside the pelvis, we're sort of staying outside the pelvis, sinking towards the table, and then moving superiorly. Here we're using the skeleton to illustrate some of the detail of working with obturator internus and obturator externus. For obturator internus, you want to be able to palpate specifically the pubic ramus and the ischial ramus. Fingers are on the inferior portion of that ramus, and then we reach inside to the medial aspect of the pelvis and put the finger pads back down on the bone. So that's somewhat reaching from the inside of the pelvis, pushing back laterally to the outside, so the fingers are resting on the medial or interior surface, and that's obturator internus and the fascia associated with that. And that's that whole region there that we're interested in working with. Obturator externus looks much the same, except to begin with, same area of bone, but we're pushing laterally towards the femur, and then we're coming up on the lateral aspect of the pelvis. So it's like a mirror image. This time we're lateral, feeling on the underside of the pelvis or the underside of the ischium and the pubic bone. And we're able to palpate a number of sites along that whole stretch of bone. Same with the internus, we want to palpate a number of sites so that we make our specific contact with specific restriction, so we can work mechanically but also specifically. Rectus abdominis and the abdominal wall needs attention, and often prior to working with the underlying psoas. And I want to show a way to work with that really has a very nice effect on all the layers of the abdominal wall, and it's a little different than some of the work that we do because there's not so much ability anymore to trap the tissue up against a bone, which sometimes sort of acts as a third hand because it gives us a kind of back pressure point. But I'll show there's a very nice way to work with this that utilizes the fingers in a scooping motion, or almost like a counter scooping motion really. So I'll rest the heels of my hands onto my model's thighs here, and then I'll take my fingers, and I'm working really with the first three fingers, the little fingers don't have much to do with this, and I'm landing and sinking towards the table. And then I'm extending my fingers but not gliding, so I'm taking up a local line of tension in the tissue. And maintaining that. And one of the times that I feel that the tension in the tissue is increased is during the inhalation, so I just provide some sort of gentle but persistent resistance to that, which increases the local line of tension in the tissue. And then during the exhale I just follow the tissue as it subsides, and then during the next inhalation I hold that tension in the tissue again. And I'd repeat that at a number of sites, and I can take that all the way up to the costal arch. I'll show more of that in a different DVD, but I'll show a couple of contexts just so you can see how that work will develop. Here we've got a scar, and I can show it in relationship to this appendix scar here. Same principle, but I'm just going to bring a little bit of focus to that, and I'm going to ask if that's okay to work there. Scars often have a strong emotional charge around them, and jumping on them and working on them willy-nilly without seeking permission is not a good idea. So just checking that that's going to be okay, landing, sinking, and as I'm sinking, I'm letting my fingers here on the scar be the sensory part of my whole body. So this is important with all our work, but particularly when we start to work in sort of fine detail with scars and we want to get really good feedback about what we're doing, we don't want our fingers to so much be too much taken up with motor work, but that they've got a lot of potential to be sensory. So where I get the juice, if you like, or the driving sort of energy for my work is all the way from my feet. And of course my fingers are doing a little bit of work as they go into extension, but I have a sense now that my whole body's participating in that, and I can feel that through to my feet, landing, sinking, taking up that tension. And because my hands are available for a sensory exploration, I can notice these changes as they take place, and I can feel a softening now starting to occur under my finger that's on top of that appendix scar. And I would just proceed in that way, and I'll show one more spot just above the umbilicus. Landing, sinking. Here I'm resting the heel of my hands on the ASIS, so I've moved up. Not pushing down, just using them as a balance point, a fulcrum. And landing, sinking, so you can see their fingers are depressing down into the wall, but not really seeking the organs behind there. And there's the scooping motion, or the counter scooping motion. So extending my fingers and connecting that all the way through to my feet. Yeah, and that just lets me feel what's happening here. Next, let's look at some ways to work with the iliacus and the psoas. And I want to introduce some positions to place your clients in that may be a little different than how you've been working. You can see here with my model that lying flat out in this supine position puts the back into a certain amount of extension, and for many people that's not problematic, but where the back is in distress and lying in this position either causes pain or just a sense of positional discomfort, then we need to find some ways to modify the position so that the work that we're doing, effectively, really the deepest work that we do in the body is the work around the psoas and the iliacus. And by changing the position, we'll be able to make the client significantly more comfortable, and this is important. So I'm using some equipment to do that. What these are just big blocks of foam, and I'm going to have Maren lift up her legs, and I'll put her onto the first one there. And you can see already that I've got quite a bit more elevation than I'd get just by putting a couple of pillows there. Maren's tall enough, I think we could almost go with the next box, and so I'm going to add another one. Just have Maren raise her legs again. And you can see here that there's quite a lot of hip flexion now and quite a lot of flexion at the knee as well. And for many people this is the first time that they can really relax into this supine position, and it takes the tension out of the front of the abdominal wall, and that makes the work that I'm going to do more deeply down into the contents of that abdominal space. Some of the structures that form the boundaries of that, the posterior aspect of it, makes it much less distressing to the patient that's already got quite a lot of guarding, spasm, hypertonicity, and other kinds of distress through that region. The iliacus is an easy one to find because we've got such an obvious bony landmark, so that's the first thing I'm showing here. I've got my fingers here right on the edge of the bone. And so there's the ASIS, point to that with my other hand, and then I can take my fingers and keep the pads of my fingers butting up against the inner lip of the ilium there and start to sink towards the table as well as angle somewhat inferiorly. So it's about this angle, and that doesn't have to be precise, it's just a composite thing. It's inferior as well as posterior. So I'll just move shorts to the side, land and sink, and with this work and the psoas work, there's very much orienting the work towards the pace of the client, and so there's been I think a bit of a tendency to go too rapidly towards the psoas in particular, and the outcome of that is an increase in muscle guarding and also I think some unnecessary arousal of the sympathetic nervous system. So if I land, I put just a moderate amount of weight in my fingers, and I'm just waiting here for a settling, and I can feel that start to happen, and this is sometimes referred to in my classes. I talk about this as the elevator effect. The elevator just goes down when it's ready, and we follow it down, rather than if you jump up and down on an elevator, it doesn't go any faster. And so it's the same thing here. Kind of just listening to the rhythm of the body, how much the body can allow this, and you'll find that your fingers, if you don't push it, just keep steady, light, sort of compressive force, that you'll find that your fingers can go fairly easily down right up against the inside, the medial aspect of the ilium. So this is useful when you've got pelvic torsion and pelvic tilt both. So with a torsion, of course, we've got one side of the pelvis forward and the other not, and so this would be useful for the side where you've got the anterior ASIS with a general anterior tilt in the pelvis. Then you've got both sides of the pelvis bilaterally rotating forward and down, and so the iliacus is useful for that as well. So this is how I'd proceed. There's not a lot of gliding motion possible here. It's mostly just about slow sinking, that kind of melting style of work that I've talked about throughout the video series. Next, I want to show some work for the psoas. And once again, I want to orient the work very much around this sense of listening to the body and also having a response to the effect that you're having as you're working, so that there's a high degree of sensitivity or listening through the fingers as we're working. If we consider that between the surface and the psoas lie the viscera, or in the vernacular, the guts, but if we consider all of the viscera through this region, then it helps us keep in mind that it's probably not going to be that useful just to try to punch through down to the psoas. And so I want to organize the way that we do this so that we respect that and allow for those structures to be moved in such a way that they can move to the side. The entry point that I'm going to take is if I draw an imaginary line from the umbilicus to the ASIS. So imaginary line from the umbilicus to the ASIS. And where that crosses the edge of the rectus, that's an important landmark. I want to be working lateral of the edge of the rectus. So if you're not sure where that is, you can ask your client to just lift their head up, and there I can feel the edge of my model's rectus is just there, and let your head back down, thank you. So I just come a little medial of that, and I start to take my contact directly towards the table. Sorry, I think I said medial of that, but I meant lateral, so I'm coming lateral of the edge of the rectus and sinking initially just towards the table. And once again employing that elevator effect, so giving a moderate amount of contact and just noticing that if I sustain that progressively my hand will be lowered down towards the table. And I have a very nice position here that really facilitates this happening very easily. And for many people with back pain, low back pain, particularly chronic low back pain, you'll discover that of course there's the need to work into the front of the spine, as we're doing here. Then there's the need to work into the front of the spine quite slowly, so that that accumulated stress that will be through this whole region, not just the muscle but the surrounding fascia and the autonomic structures, the autonomic nervous system embedded through all of that fascia, all of that will respond to slow work in a way that it can't respond to fast work. So there's sinking, noticing my hand is progressively going towards the table. If I reach a barrier and I feel that I would have to force to go further, that's where I stop and I wait, rest there, and let the body sort through the sensation. Is this a useful sensation, or is this a sensation that's going to overpower me, do damage perhaps? Some images that will work, or ways of using language and the client's self-sensing to augment what's happening. I can ask my model here just to get an increased sensation of receiving the weight of my hand. So finding the layer where you're meeting my hand, and then discovering that perhaps you can allow that contact to be received in a little bit deeper. So perhaps a centimetre below where you're sensing it. And even as we're talking and having this kind of one-way dialogue in terms of the words, but certainly a two-way dialogue in terms of what I'm feeling at my hand here, I get this sense that indeed there's a lot of potential there for discovering the ways to let go and allow that opening to take place. And there's the fairly typical therapeutic breath, and a big change right on the heels of that during the exhale phase, my fingers going in much further. Now I'm angling towards the spine slightly. I've sunk, gone towards the table, and now that I'm well and truly engaged towards the back of the abdominal space, I've put an angle towards the spine. So I've effectively gone like that, and that's taken me round the side of the descending colon. And there's a tendency or possibility, a potential to pinch the colon here, and that's just generally painful, unpleasant, and has no real therapeutic effect at all, really working against what we're trying to get a hold of here. But you can see that because of the pace that I'm going, even if this was the first time that I'd done this with my model, she'd have lots of time to explore the sensation. And I can't stress that enough when we're working so deeply into the core of the person. Now, this is all being done in this very supported position, and my model's fairly passive. And this is excellent, where there's just not that level of function where you can expect people to be able to do a lot of coordinated movement with the work that you're doing. But I'd like to move from this, and this would be my first style of work. This is the way I'd proceed with the psoas in my practice. When someone comes in and their low back is in distress and they have a lot of trouble lying with their legs out, so that their back then goes into extension, and all of that creates positional discomfort. But now I'm going to show a way to proceed with this that's a little bit more dynamic and might be something that I'm building towards as the back starts to move out of discomfort and pain. So here's the setup for working with the psoas. Still supine position, of course. This time the knees are up, so I've got again a high degree of flexion here, and the back is dropped towards the table in much the same way as it was with the big boxes and bolsters in place. But this gives us a couple of advantages that we don't get from the other position. And one is that we've now got a closed kinetic chain in the legs, and so the feet are in contact with the table. So there's more proprioceptive information coming from the joints in the leg, particularly around the tarsal bones, the ankle, even at the knee. And as I'm working with Maren in the next sequence of work, I'm going to have her utilize some of those proprioceptive processes while I'm got my finger on the psoas. So I'll take advantage of the pliancy that we've developed in the previous release, and so I'll move in to the level of the psoas a little bit faster this time. Again, not wanting to overpower, but just assuming that there'll be a fair amount of receptivity there. And here's the beginning of some active movement with this work. So I'm going to just encourage you to have a sense of just pushing lightly into your foot, so you get just a slight increase in the sensation of pressure there on this opposite side. So that's on the contralateral side. On the ipsilateral side, I've got my fingers on the psoas there, and I'm just going to have Maren lift her leg up and then just start to slide it out across the table. It's probably not the easiest thing to do because we're working straight onto the vinyl here, but nevertheless she's able to do that. And that, of course, is a lovely long eccentric contraction, and the pelvis is stabilized because she's taking advantage of this closed kinetic chain situation. So actively finding the foot, not over pressure, but just enough to create a sense of connection. That helps stabilize the leg, the pelvis I should say, and the lumbars. And then here's the eccentric elongation. I can hang on during the concentric contraction. That certainly confirms that I'm on the psoas. I can feel the muscle popping into my fingers, but I'm not nailing it down at all. And then once again, I'll just encourage Maren, find her foot in her awareness, lightly take up a tension through the leg. Yeah, so just a slight increase in the tone, and then maintaining that, sliding the leg out, and then adding a little bit to this just by asking you to lift your chin slightly. So just letting your chin up, and that's activating the whole extensor chain down the back of her body. And as the extensor chain activates, it means that the flexor chain will relax. So we're getting this lovely lengthening right through the front of the body, in the surface, deep along the front of the spine. Closed kinetic chain, lots of sensory information arriving into the nervous system. And this is much more active, much more about integrating the release into movement, and that's ultimately where we'd like the work to go. So just to restate some of the features of this more active thing that I've been doing: the feet in contact with the table, the client instructed to give just enough tone to get a good connection to the foot, and that will help keep the pelvis stable and the lumbars. This hand's in the psoas, and then the leg would be starting from the flex position at the hip, and as your client's sliding their leg out, you're just tethering the psoas slightly, they slide, and then the chin goes up lightly, and that quite often as the chin goes up you'll just feel the whole front of the body come out of a shortened, flexed holding position. Okay, and that concludes the psoas. Posterior aspect of the muscles that wrap around the abdominal space. So the most posterior of those is transversus abdominis, and then lying posterior to that again is the transversalis fascia, and then lying even behind that is the peritoneal fascia, connective tissue, so the peritoneum. And what I want to show here is a way to work with the suspensory ligament of the bladder, and that's fairly simple to do. And if we just understand that it lies between the umbilicus and the bladder, and it's in the level, it's a thickened piece of fascia that lies right at the midline at the level of the transversalis fascia. So we don't have to push through into the intestines to affect that. In fact, we'd like to just get slightly above that level and then work from inferior to superior. So this is how that looks. So I just take my thumbs at the midline, so I can feel the pubic bone here. And I'll just move that hand out of the way to make sure you get a really good view of how far down I am towards the pubic bone. So I can feel the pubic bone just resting up against my thumbs there. I'm at the midline. I take attention into the tissue. So I land and sink and then take up a line of tension. And start to work that from inferior to superior. So this is through the rectus, behind the rectus sheath. And I'd repeat that 5 to 6 times, and this is a quite predictable change in the respiration. It feels to the client like they're getting all this facilitation of this nice opening inhale and a deeply relaxing exhale. The use of this does relate to breathing, so it's not just about affecting structures that lie within the pelvis, so it will de-tension the surface fascia that's holding the ribs down, but also will affect the bladder, and this can be problematic. Postpartum generally is when you see changes in bladder function, bladder position, cause prolapse uterus. Can also be a difficulty after childbirth, and there's many things that can be done to work with that, but this is an especially useful one that I find produces good results in the vast majority of people. So it's just that span between pubic bone, umbilicus, just keeping in mind that we're not trying to get right along the front of the spine, we're still in the outer wrapping of the abdominal compartment. It's a lovely way of working to do a pelvic traction that can have a profound effect on the sense of tension around the lumbar sacral area, within the lumbar spine itself, and also greatly increases the proprioception in that lumbar sacral area. And some of the recent presentations at the World Congress on Low Back Pain point to the fact that many people who have back pain have very poor proprioception in that area of their body, and so part of the condition that those people are suffering with is just an uncertainty about where their back is and subsequently what the muscles should be doing there to help support it. So for good muscle tone, the body needs good proprioceptive inputs, and all of the things that we do in this work contribute to that kind of sensory stimulation that helps proprioception and subsequently helps the coordination of the muscles that create stability and strength in the low back. I'll be able to see my hand once I start working, so I'd like you to see what my hand's going to be doing in the back, and it's going to look like this. Here's Merrin's sacrum, there's the coccyx, there's the PSISs, and so my hand's going to reach up like this, and I'm going to be putting this lovely distal drag through the thoracolumbar fascia, and at the same time I'll be counter-nutating the sacrum, or just bringing the sacrum out of its anterior position and letting it settle back a little bit more towards neutral. So that will look like that. So there's my hand. You can see even from that position that I'm able to put some tractioning force through there, and now I'll have Merrin lie on her back again, and knees would be up, thank you, and if you can just reach away this time, so I'll just have you push into both feet a little bit and start to roll your pelvis up, so you get a sense of going one segment at a time through the lumbars. And I've put my hand in there, and I've asked now for you to rest back down. So I've got my hand in that position I was just describing. Now I lift my fingers towards the ceiling, so I can hook into the thoracolumbar fascia, and then I start to put that distal drag in there. And you can see that it just lets the lumbars rest back towards the spine, lumbars rest back towards the table is what I meant to say, and also how it counter-nutates the sacrum. And the net effect of that is just feeling that the pelvis is more horizontal and that the lumbar spine is supported by the table. All right, in the pediatric population, we often have to be a little adaptable in the approach to what we're doing, and that can sometimes mean more things have to happen at once to get some of the work to happen. With the psoas, some of the ways that we can work would be the same as what we saw in the adult model. That could include bolstering appropriately to take some of the excess tone out of the area, or certainly that would be beneficial. And sometimes that's not possible or necessary because of the size of the child. It's very often easy then to just provide some of the support. And here I can be a little bit kind of directive with about what happens with the legs. I can just support them here, and I can then start to do some work in the area of the psoas and sinking in here. Just same basic guideline for landing and sinking as I followed with Merrin. But just sort of taking a little bit of control of the legs if needed here, and I might not have to do that every time, but it's worth having some options. The other thing that you might want to do in the pediatric setting is leave one leg down, and then I'll take up a hold into the area of the psoas, and I'll then provide some passive movement, because of course working with some sophisticated closed kinetic chain positions is just not going to be possible depending on the degree of neurological involvement within the child or the adult for that matter. And so we have to just make up some ways of putting some movement and some lengthening kinds of movements into the tissue as we're working. And so here's a nice way just to take the leg. I can just lower that into extension. I can slightly internally rotate the leg, and that will also give the psoas a little bit of length as well, because it acts mostly as an external rotator. And so these are some ways that you could explore working with the psoas. That I found to be very useful.